On an overcast day in New York City, Dr. Jeffrey Weber of the NYU Langone Medical Center comments that physicians can begin to forecast brighter days for their patients with metastatic melanoma.
Having a diagnosis of metastatic melanoma 10 years ago was effectively a death sentence. You had probably a 10-year survival of a little over 10% for your melanoma patients who had metastatic disease. That's pretty dismal. With ipilimumab, which was the first immunotherapy to be approved back in 2011, it probably went up to 20%. With pembrolizumab and nivolumab, the so-called PD-1 antibodies, that probably has gone to at least 30%. And if you look at the emerging data with combining those drugs, ipilimumab and nivolumab, it may well go up to about 40%. So we're slowly inching our way upward in the survival curve.
With the newer treatments and the newer combinations, we have about 70–80% of patients alive at 1 year. We're really excited because this is the first time that we've been able to tell patients we have something that can really improve their outcomes.
For the first time in our field, we talk about the C word. We talk about cures to patients with melanoma. Melanoma is one of the few cancers whose incidence year by year continues to rise. This year, I think the American Cancer Society estimates about 87,000 will be diagnosed with melanoma, the vast majority of which will be early primaries, so-called stage 1 and stage 2 in the skin. Florida, where I used to practice, per capita, it had the highest rate in the United States because it's in a more southern clime, a lot of sun, a lot of people live in outdoor styles.
Unlike other skin cancers, melanoma risk is not related to the extent of sun exposure.
We do know there's an association of melanoma and sunlight, ultraviolet light. It's different than some other sun-related skin cancers such as squamous cell carcinoma. The more sun you've had, the greater the chance of getting squamous cell carcinoma, and it occurs primarily on what we call chronically sun-exposed skin. Melanoma frequently arises on what we call intermittently exposed skin. For example, the back, it gets less sun exposure than your face, yet it's a common site for melanoma. And interestingly, when we look at people of color, they're getting most of their melanomas are on the feet or on the hands. So clearly it's not a sun role there, more like an internal cancer that arises for reasons we're not sure.
Well, melanoma is it's the only cancer of skin cells that will potentially be lethal. It is a malignancy that results from transformation of your melanocytes, which are the pigment cells that give us all our pigment. We all have some pigment, some more than others. That often is a pigmented lesion because, as you can imagine, when the transformed cells, the abnormal cells, are melanocytes, the cancer equivalent is going to also make pigment or melanin. Almost all melanomas will be diagnosed by a dermatologist, a primary care practitioner, someone who sees the skin, sees an abnormal lesion. The hairdresser or barber notices an abnormal pigmented lesion under the hairline where the patient can't easily see it, points it out to the patient. They then go to the dermatologist, get a biopsy, and it's melanoma, and we always say, boy, you better give that hairdresser a really good tip.
People often say, well, what should I look for? So many years ago, our group created ABCD to talk about the physical features of melanoma, and more recently, we added the E for evolving, which represents change in the appearance of a melanoma. So I think everyone knows the ABCDs: asymmetry, irregular borders, multiple colors, and a diameter about the size of a pencil eraser or larger. But probably the most important factor is the E, the evolving. That captures the new or changing lesion. We hope that when we do find a melanoma, it's at the earliest possible stage where the patient can be cured by surgery.
Probably 90–95% of patients are cured by surgeons in the office of the ambulatory surgery center with smaller operations. Unfortunately, there still are those patients that do present with thicker melanomas or locally advanced melanomas. For those patients that we know will require treatment above and beyond surgery, we feel very strongly here at NYU that a patient be seen in a multidisciplinary fashion in real time. And so we've worked really hard to align our practices in a vertical way here in this building so that when the surgeons are seeing patients with melanomas, the medical oncologists are available at the same time.
I, for example, have clinic on Monday when the primary surgeon who sees melanomas is in clinic, so there's an easy communication. A patient will come to see the surgeon and need to see me. They'll just walk upstairs to see me a couple of flights or take the elevator up.
When we see a patient in the office and we have the final staging, then we discuss with the patient what their different options are. Since I say, okay, look, I'm going to pretend you know nothing about melanoma and we're just going to start from the beginning. I talk all about the immunotherapies, how they work, how they block a breaking mechanism in the immune system to rev the body's immune system up, where in the T-cell life cycle they sort of work, and then talk about the targeted therapies, talk about the side effects for everything.
I make it clear that while we don't harp on the C word, the cure word, it is now possible for patients to have long-term survival with immunotherapy and even targeted therapies.
So I certainly have patients ask me, if they're dying. And I said, no, you're not dying right now. But what I tell all my patients is I say we take it day by day, we take it treatment by treatment, we take it scan by scan.
Hi, my name is Kelvin and I work on the team that creates the content that you've just seen, MedscapeTV. If you like the content and want to see more, click on the button to the right and it'll take you to the full series.